Great. Okay, so we're going to cover the hearing screening portion, and this information is for birthing centers, hospitals, and midwife practices. So you will hear us call the Newborn Hearing Screening Program, or the EHDI program, which stands for Early Hearing Detection and Intervention. We're at the Department of Health, at Children's Medical Services, just like the genetic screening program is at the same place. So our job is to promote and support statewide newborn hearing screening and follow-up. So we work in collaboration with our hospitals, our midwives, parents, PCPs, Indian Health Services, audiologists, ear, nose, and throat doctors, and our early intervention program, the FIT program. And this is the goal of newborn hearing screening. The goal of newborn hearing screening is not to have a baby pass the hearing screen. You hope that they do pass that newborn screen, but the goal is that all infants with hearing loss are identified as early as possible, and they receive timely and appropriate audiological, medical, and early intervention services. So that's what you're accomplishing by screening babies' hearing, by reporting all of your births to our program. So Rihanna Garcia is our coordinator. We have a management analyst that will work with our hospitals and midwives to obtain and manage hearing screening data. That position is currently open. We have a consultant, Jim, who provides quality assurance and data analysis. And then there's 4 of us that are contractors that do all of the newborn hearing screening follow-up. And we've been working in this field for decades. Our backgrounds include education of deaf and hard of hearing children, early intervention services, pediatric audiology, and managing hospital hearing screening programs. So it is required in New Mexico to screen the hearing of newborns, just like it is in genetics. And we've been screening newborns since 2001. So we have national 136 goals, and we're talking about first month of life, the 3rd month of life, and the 6th month of life. And this came about because we had decades of research that showed very poor outcomes for children who were deaf or hard of hearing. In the past, we did not have newborn hearing screening, and children were identified very late, sometimes not until they went to school, to kindergarten. Many times they begin to suspect the child had a hearing loss around 1 year of age, but it could take a long time to actually identify hearing loss. So those of you who are birthing babies in New Mexico, you are really impacting the quality of that child's life. And it is life-changing for the child and the family. So we want all infants to have their hearing screened shortly after birth, or ideally by 1 month of age. Hearing loss is the most common condition present at birth. It's low incidence. It's typically 3 in 1,000. But if we don't identify those 3 babies right away and get them the follow-up, the services that they need, it's going to impact them possibly for the rest of their lives. So thank you for this service that you provide. Even if you don't screen a baby at your facility, you are required to use our reporting form and report that baby's birth to us so that we can help the family get the hearing follow-up that their baby needs. You want to have good screening protocols in place. You want to have 365 days of coverage at your facility. You want to have good training. For those of you with a new machine, you want your manufacturer to provide that training for your staff. There's other resources to look at the other aspects of hearing screening, but training on your individual machines, excuse me, should be provided by your manufacturer. So the next goal is hearing loss in infants is identified before 3 months of age. So again, if the one doesn't happen in that first month of life, it's going to make the 3 months and the 6 months late. Excuse me, spring allergies. You had limited resources for diagnostic audiology in New Mexico. And sometimes there's a waiting list for an appointment. So again, that's why the 1 month is so important. And then by 6 months, we want to know our infants who are deaf or hard of hearing. We want them referred to early intervention services. We want the family and child to begin receiving early intervention services. This is so critical to the success of the child and the family. Early intervention will help the family understand the child's hearing loss, the child's listening devices, how to take care of those devices, how to put them on their child. They will have strategies to support their child's communication and language development throughout their daily routines. It will help with the stress associated. Sometimes parents feel guilty. Why did this happen? Did I do something wrong? And early intervention helps with all of those issues by providing factual information and ongoing support. So there is a lifelong impact if children don't meet 1, 3, and 6. So families, when they find out that their child is deaf or hard of hearing, they will go into a grieving process. And when children used to be identified late, families felt very guilty. There was a lot of stress and blaming in the family. Children made slower progress. It just was very difficult for the child and the family. In early identification, families move through the grieving process very quickly, and they get ready to do what they need to do to support their child's development. We know from our research that when we identify our babies and they receive appropriate early intervention services by 6 months of age, they're going to have language like their hearing peers, and it's going to avoid developmental delays, especially in the area of social skills, communication, and language skills. Late identification of hearing loss is a neurological emergency because it affects the child's language center and listening center in the baby's brain. So it's actually affecting the baby's brain because babies process sounds with their brains. It's also a developmental emergency, primarily in communication, language, and social development. So any delay in language acquisition, and that's the primary impact of hearing loss, affects the child's cognitive development, their school success, their mental and emotional health. And we use language for critical thinking, for problem solving, for supporting children and forming relationships with other people. So language communication skills are critical to all of us. And we want to identify our children as early as possible and make certain that they are achieving language as like their hearing peers. So your screening procedures, you want to screen the newborn no sooner than 12 hours after birth, so you don't have false positive rates because those significantly decrease. You can screen as early as 6 hours after birth if the child is doing well, but we do recommend about 12 hours after birth and hopefully within enough time to screen one more time if you need to. Most of our parents go home with their babies in that first 24-hour period. So you want to think about when the child was born and when the baby and baby may be discharged. So you want to get that hearing screen done. You want the newborn to be medically stable, not being seen by other healthcare professionals. The baby hasn't been poked or prodded, is very calm. Quiet or sleeping is the best time. And really 1 hour after feeding is ideal. You want to swaddle the newborn, dim the lights. You want a quiet screening environment away from background noise. If you're screening in the parent's room, you want to make certain that no cell phones are on, there's nothing impacted, the television is off, there's no kind of equipment interference. Your machine will let you know that, and you maybe will need to move the baby to a quieter environment. You want to screen both ears with a maximum of 2 screenings per ear. You only do a third screen if the infant passed in different ears in the first 2 screens, or if the second screen was incomplete. So if the baby passes in the right ear and not in the left in the first screen, you're going to do a second screen and you're going to screen both ears. It's not a complete screen unless you've screened both ears, even if the baby passed in one of those ears in that first screen. Infants, as I said, and let me just say this one more time because it's so important. The infant must pass the screen in both ears during the same screening session for it to be a pass. If the infant is fussy or moving, or you're having trouble getting anything to stick on the baby, or the probes are not fitting in the baby's ears, that is an incomplete screen. That is not a refer. Please do not mark those as a refer, because a refer indicates that you did a good hearing screen and that ear did not pass. You want to, of course, follow infection control procedures. So for screening tips, this is one of the best resources. It is an online training curriculum. It takes 2 hours to complete. It's free of charge. You can get a certificate. Sometimes you can get continuing education credit. For midwives, it will apply to your yearly continuing education. It's at your pace. You start the process. If you have to leave, you can come back and you'll start again at the same place where you left. If you don't, you'll go through a section of information, then you'll take a short test. If you don't pass that test, then you will go back to that previous section and then take the test again. It's really effective. You might want to have your screeners take this once a year. Again, it's only 2 hours, and you might want to keep a copy of their certificate because you will get a certificate for completing this training. So if the baby refers or the screen is incomplete, you want to communicate those results clearly to the parent. So I don't use the term refer when I'm talking with parents. I use the term did not pass. And what that means is their baby needs additional hearing testing as soon as possible. You want to make certain that you're not communicating this information in a way that the parent is going to think, well, it was an issue with the probes, or it was an issue with my baby being fussy, or they were struggling with the machine, it wasn't working right. My baby would have passed had everything worked out like it should have. It's very important that the family understands this means their baby still needs an outpatient hearing screen. I've had parents who refused to do hearing follow-up because they thought someone communicated to them that their baby would have passed had things worked out differently. You want to make certain screen results pass in both ears, refer in one or both ears, incomplete hearing screen are included in the discharge paperwork. This is really critical that parents understand this. It's really important that the primary care physician who's going to follow that baby after discharge understands that the baby still needs hearing follow-up and that the physician schedules that or refers the baby for that hearing follow-up. If you're doing outpatient hearing screens, you really want to schedule that before the baby leaves the hospital. You want the parent to know the date and the time that outpatient hearing screen is scheduled, and you want to make certain that you review your protocol. So for inpatient hearing screens, one of the protocols that you want to meet is that at least 95% of the births that you have each year are screened by your facility. If you're doing outpatient hearing screens, you want at least 70% of those children, those babies, to come back to your facility for that outpatient hearing screen. So you always want to be monitoring the success of your screening program. You're wanting to look at your refer rate, and you want it to be less than 4%. If it's higher than that, or if you're having a lot of parent refusal of newborn hearing screening, you want to assess what might be happening and take steps in terms of your policies and procedures and your training and supervision to correct those. Because again, this hearing screen by 1 month of age is so critical to this baby and the baby's family. So you have, and this applies not only to hospitals, but to birthing facilities and to midwife practices. So depending on if you're a hospital or a midwife practice or a birthing facility, hospitals do upload their data directly into our database on the 1st and 15th of each month. Midwife facilities, midwife practices, birthing facilities could be reporting in a different way, but you need to know what your reporting requirements are, and you need to send us your data. And we use the newborn hearing screening report and referral form. That has to be completed and faxed, securely emailed or mailed to our program within 48 hours of the infant's discharge. For the infants who refer, did not pass in one or both ears, who have an incomplete screen, who are transferred, who are not screened for any reason. Maybe it's a medical reason. Maybe the parents refuse the hearing screen. Your machine is not working. You don't have screening supplies, or the supplies don't work for that baby. The baby's ear canals are so small that the probes that you have do not fit that baby. If a parent refuses, we use the same refusal form for both genetics and hearing. It's very important that you cover that information like you heard before in the previous presentation. You let the parent know why this is important, and you have them sign and date that form. So if that child is ever identified as deaf or hard of hearing, and the parent comes back on whomever, that you have that documented. And they need to understand the implications of not having their baby screened. And again, as a hospital or a birthing facility or a midwife practice, you want to assess, why are parents refusing? What might be the reason for that? Is it the way it's communicated? Is it a cost issue? Is it a lack of understanding on their part? So what can you do different to support babies and having this hearing screen in the first few hours after birth. And please let us know if the child passes away. It is so devastating, especially to the family and to us, if we call a parent because we don't have screen results on their baby and the parent tells us that their child passed away. So this is the reporting form. And again, it's not only for hospitals, but it's for birthing facilities and midwife practices. You're going to fax it, securely email it, or mail it to our program within 48 hours of the newborn's discharge or transfer. And the information is at the bottom where you send it to. I'm going to break this form down into different sections and cover each section. The top of the form, please fill this out as carefully as possible and as legibly as possible. You have the option of using a form you can fill on a computer, or you can hand fill in the form. So please put your name, or whoever fills out this form, we need their name and phone number. And when they send it to us, we need that child's medical record number, the name of your facility, who to contact, and their phone number if that person is different from the one who filled out the form, the baby's last name, the baby's first name. And as you know, sometimes it's baby girl Sanchez or baby boy Smith. If that's what you have, if the family hasn't named the baby before discharge, then that's what you put in. The baby's last name, first name, the baby's sex, the date of birth, and the date of discharge. And again, we need this as quickly as possible because those 4 follow-up coordinators are going to begin working with the family and the doctor on the babies who didn't pass or didn't receive a newborn hearing screen. So we definitely need to know the doctor who will follow the baby post-discharge. This is so critical, just like it is that you heard in the genetics presentation. We're going to work with that doctor. Sometimes families move or they've changed their phone numbers. The doctor typically always has the correct phone number and address of the family. The doctor may not know that the baby didn't pass the hearing screen. Sometimes parents don't remember what they were told. Sometimes doctors don't look in the discharge paperwork. A lot of things can happen, so we need to communicate with the doctor as soon as possible. Many times the doctor has to refer the child for outpatient hearing screen or diagnostic audiology so that that facility can bill the baby's insurance. And we're going to stay in contact with the family and the doctor until hearing follow-up is complete. This needs to be really carefully filled out: mother's name, mother's date of birth, primary language. It's really important that if the family is English, Spanish speaking, speaks Navajo, we need to know the family's primary language so the follow-up coordinators can communicate with the family in the language that the family uses. The email address, the mailing address of the family. I don't know why this is doing that. Again, we're going to stay in collaboration with the family until the child's hearing follow-up is completed. We know the child's hearing status, and if the child is identified as deaf, hard of hearing, we're going to refer the child with parent permission to early intervention services. Please always include the message phone number. It's always amazing to us doing follow-up how frequently families change their cell phone numbers. So one of the places that's critically important on the form is for you, to the best of your ability, to identify any risk factors for hearing loss. If the baby receives any ototoxic drugs, such as the mycin drugs. The baby needs those drugs to support the baby's health, but those drugs are toxic to the ear and can result in hearing loss. Prematurity, the baby spends time in the NICU, especially if the time is greater than 5 days. If the child has atresia microtia, that's when you look at the ear, sometimes the entire outer ear flap is missing, or the canal, there's no opening in the canal, or the canal is so small that you can't really hardly see an opening. If there is a craniofacial anomalies, such as a cleft lip and family history of hearing loss or a syndrome. I recently just received a referral on a baby who received ototoxic drugs, was premature and in the NICU, and the baby has trisomy 21 Down syndrome. So if you don't know if the baby has any risk factors for hearing, then go ahead and check it there, but please identify these. There's many, many risk factors for hearing, but these are typically the ones that you can identify in those first few hours and days after birth. We track risk factors for hearing loss in our program. Children birth to 4 years of age in New Mexico who have a risk factor. We want to see if those children develop a hearing loss later. It's really critically important that doctors know if a child in their practice has a risk factor for hearing loss. We do have children that pass their newborn hearing screens and later develop late onset hearing loss. So parents need to know their child has a risk factor because they want to monitor their communication and language, their attention to sounds in the environment, how they respond to communication directed to them. Do they respond to their name? Are they starting to make sounds or words at the appropriate developmental level? It's very, very important. Depending on the risk factor, the child may have an audiological evaluation around 12 months of age, maybe sooner if parents express concern. But the doctor needs to know about this so the doctor can make that referral and support the family in getting the child to that audiological evaluation. So these are the hearing screen results. So you put the date section, you put the date of the screen, you're going to click on the arrow and it will go down to refer or to incomplete. So in this screen, remember you're screening both ears during the same screen. You want to put the results for the right ear and the left ear. If the baby didn't pass in one or both ears in that first screen, you're going to do, if you have time, before discharge, you're going to do a second screen. And you're going to do a third screen if that second screen was incomplete, or if the baby passed in different ears in these first two screens. We need this information as quickly as possible. We're trying to help families meet that 136 timeline for their child. We don't want to lose children in our state, and we do, to loss to documentation or loss to follow-up. If we lose children, it can result in late identification of children who are deaf or hard of hearing. Excuse me, and we report our screening results yearly to HRSA, to Health Resources and Services Administration. And that is numbers data. It doesn't provide any personal family, child specific data, but just numbers. I apologize again for my scratchy throat. We also want to know, and this is toward the bottom of your screening form, The children identified without a screen, and the reason we need to receive that form from that the parents sign as to why they refused the screen. We very much need to know if that child was transferred to another facility. When that child was transferred and where that child was transferred, because the follow-up coordinator assigned to that child will follow that child and get the hearing screen results from that facility. Here is the information at the bottom of the form on where you email, fax, or mail the form. And there's phone numbers there to reach our newborn hearing screening program. If you need forms or if you have questions, you have data upload questions or need some assistance. If you're providing an outpatient hearing screen, you want to schedule again the outpatient screen before discharge. We really see the numbers go up if that happens. It's really hard for families when hospitals say to them, do a walk-in within 2 weeks, come back within 2 weeks. I recently had a family who lived an hour away from the hospital. Her baby didn't pass the hearing screen, and she was told to come back in 2 weeks, just walk in. So this mother told me, I had to get childcare for my children. My husband had to get a ride to work, so I had the car, and he didn't want to have to do that. I traveled with my baby for 1 hour, round trip 2 hours. And I got to the hospital and they were having a lot of deliveries and they sent me away. And she said to me, we can't go back. Those were the resources that we had and we don't have them again. So if you're going to have that procedure in place, please have some coverage available when your nurses are very, very busy. Make certain that that parent that shows up with that baby as a walk-in has coverage, that that child's hearing is screened. You want to include the date and time of the outpatient hearing screen in the comment section at the bottom of the report and referral form. You want to send us that form within 48 hours of discharge. And just so you know, some hospitals will go ahead and hang on to that form. They'll complete most of it and they'll hang on to that form until that baby either comes in for that outpatient screen and then they send us the form, or the baby doesn't come in, no shows, and then they let us know that. They send us the form then. You can do it either way. So if you're going to do it immediately and that baby's coming back for an outpatient screen, you're going to be sending us 2 forms. You want to provide the results of the screen unless you hang on to that form and wait until the outpatient screening is completed. So why we need these results, this referral and information forms so quickly, we don't want to have to wait until we receive your upload. We want that report and referral form. We are signed by the office, one of us, depending on the area of the state that we cover. We're going to take that information, we're going to phone or text the parent. And depending on what the family says to us, we may make a phone call or send a fax to the child's PCP or the nurse. We're going to work with both the parent and the physician until all of the follow-up is completed. If the child passes that outpatient hearing screen or passes that audiological evaluation, we're going to close that child's record in our database. If the child is identified as deaf or hard of hearing, we're going to refer that child with parent permission to early intervention services. and we're going to stay in contact with that family until they've completed that initial process with the referral and they have a family service plan. We're going to also, if the child has other health conditions, a heart condition, a kidney condition, a syndrome, and the family would like some additional support and they will qualify, we will refer that child to Children's Medical Services for some of the other services that are provided by the agency we work for. And then once hopefully that 136 has been met for every single child birth in New Mexico each calendar year, we have the information and we close the child's record in Cactus, which is our database. So now is a time for questions. And Rihanna Garcia is online and she can certainly respond to any of your questions too.
Okay, I'm looking at questions here. Can we get the slides of this training?
Yes, the slides will be sent to you after the training.
Great. And then Marin asked, is this form what we use to communicate the death of a baby?
Yes, yes.
Okay. Marin also asked, if the maximum 2 screenings have been done and not passed, why would an outpatient hearing screen need to be scheduled? Would that be in the case of incomplete screenings?
That is an excellent question, and thank you for asking that. We have limited diagnostic audiological resources in New Mexico, and many times babies don't pass the newborn hearing screen for a variety of reasons. Sometimes it's because they still have the birthing debris, the vernix, in the ears. The ears are still wet. Maybe it's not a good hearing screening procedure, or the baby's really fussy or myogenic, or the family leaves early. So just sometimes there is an outpatient hearing screen that's conducted either by the hospital, it could be a physician's office. Sometimes the School for the Deaf does outpatient hearing screens for us. The birthing facility can have, or the midwife practice, some of those have hearing screening machines. So often an outpatient hearing screen is done. And that's why that 1 month is so important. We want to try to get that accomplished within that first month. Inpatient or outpatient hearing screens, we know the results. If the child passes, we have those results. We close that referral. If the child does not pass, then we refer that child to audiology. And we want to get that child's appointment scheduled. We're talking with the family to make certain that they understand how important this appointment is and what to do if they need to reschedule. What are the instructions for the appointment? We'll review those with the family. And if families no show, we will do reminder text and phone calls if that appointment gets rescheduled. So that was a very good question with maybe a muddy answer. Sometimes a third screen is done, and many times the baby passes that third screen.
Great. So another question, do you have a list of all audiologists who perform diagnostic ABRS?
Yes. So we do, and it's not that many. And if it's a sedated, if the child, another reason for the 1 and the 3, if the child gets older and older and is approaching 6 months of age, ideally you want to get that that evaluation done as soon as possible, because if a child gets closer to 6 months of age, then they're going to need to have a sedated auditory brainstem test, because you just can't test an awake child. It's too difficult to get them to sleep. So that's why that 1 in the 3 is so critical. And we need your support so that we can meet those timelines and that we don't have a lot of babies needing a sedated hearing evaluation. But there's not that many. For a sedated test, you're going to be going to Albuquerque or Texas or Colorado. For an unsedated test, we do have a facility now, teleaudiology project in Gallup. We can get unsedated ABRs, a couple of places in the Southeast region. But again, most of the facilities are in Albuquerque. We can include that list with the PowerPoint after this training.
Excellent. Yeah, that was a request to have a copy of the list. So, okay, next question. Is there a requirement for completing all 4 points on the OEA? Our training said that 3 points was a pass.
Yes, that is the procedure that we will take as a pass. That's the procedure that's followed with all OAE screeners. Our birthing facilities, our midwife practices that are doing OAEs, our early intervention programs that do OAEs, and our Head Start programs and early Head Start programs often provide OAEs. So that is what's acceptable.
Okay, and second part of that question is there a protocol for doing tympanography if the OAE is passed, or only if not passed to collect more info?
So ideally, you would do both. I know that in early intervention, the early intervention programs were required to do both. Now they're no longer required to do both. When you're doing a hearing screening, or you're doing you're checking the tympanography, if you do, the more you do, the better you are, the quicker you are, the more confident you are. So if you have the equipment, you can, I would say, and the time to go ahead and do both. But it's not required unless the baby does not pass the OAE first.
Great. Another question, how long after their failed second screen do we schedule them for that outpatient screening?
Ideally, as soon as possible. Some hospitals will wait 2 weeks, and some physician practices wait 2 weeks. So I would say within 2 weeks. You want to get that accomplished within 2 weeks of life.
Great. I don't see any other questions in here. Hopefully I didn't miss any. Participants are also welcome to unmute themselves and ask questions as well. So we'll wait a minute and see if there's any more questions in the chat or if anyone wants to unmute. Okay, here is a question. How long do we have to wait if the baby is on gentamicin to do a hearing screen for the baby?
A great question. And usually that hearing screen, that second screen, is just before discharge, as close to discharge as possible. But then letting us know that, and letting the doctor know that that baby did receive an ototoxic drug.
Great. Another question, can you explain why both ears need to be passed in the same screening?
Because that is the recommended protocol. You want to, if a child passes in different ears in two different screens, or if you only screen the ear that didn't pass, maybe that first pass was a false pass. So you want a good, robust pass in both ears during the same screen, because you can get false passes. And again, you don't want to screen and screen and screen. One of the parents that I worked with years ago in New Mexico, she worked at a hospital in the southeast region of the state, and they all knew her and loved her. Her daughter was born. She didn't pass her hearing screen. They kept rescreening that child. They didn't bring her back. You know, the mother reported to me, they didn't bring her back. They didn't bring her back. She really was getting worried, and they kept trying to rescreen her to try to get her to pass. When you rescreen and rescreen and rescreen, you can get a false pass. You don't do that. Again, the goal of hearing screening is not to get the baby to pass, but to provide a good quality hearing screen and identify those kids that need additional hearing follow-up.
Great. Okay, another question in the chat. Is it okay to test the baby on low flow off the wall oxygen?
Unless you see from your machine that it's causing some interference with your equipment. If it's causing interference with the equipment, can you get permission from the managing doctor caring for that baby to turn that off for a brief amount of time? And I've heard from different screeners that sometimes you're getting some interference and sometimes you're not. So, and again, this could be a medical reason why you didn't test the baby, right? So if you're getting interference, it's not okay to turn that off. So try to test that baby just before discharge.
Great. And how many hours should go in between rescreenings?
Another great question. So if the baby's really doing well, you can screen as early as 6 hours. Ideally, you wait to 12 hours. So for the second screen, and again, just after feeding, very calm baby, right before discharge. And so it's important, it's a tricky time frame, right? Because you can get busy, hospitals can have complicated deliveries, or a number of deliveries that perhaps were unexpected. And so that can impact getting that screen just before discharge. So that's why, if you can, as part of your protocol, you want to have somebody backup that could go ahead and take care of that baby before discharge. And discharge can be moms have reported to us, it was really crazy. No, they didn't rescreen. It was just so crazy. We thought we weren't going home for a couple of hours, and then all of a sudden they brought my wheelchair and my baby, and we were out of the hospital. So monitoring that, especially at a birthing facility or at a hospital, you're monitoring what's causing babies to be discharged without that, second screen. And ideally, you get 2 screens if you need 2 screens. But you work within whatever the situation is for that child and baby.
Excellent. I don't see any more questions in the chat. We just have a couple minutes left, so put your questions in now, or you may unmute yourself and ask your question directly.
So Rihanna, do you have anything you would like to share? And I think Gail One of our follow-up coordinators is on too, and she's a pediatric audiologist. Gail, do you have anything you would like to add?
Can you all hear me? I'll try to
Yes.
talk.
Yes.
Yes.
Sorry. Thanks, Suzanne. I had written down, in addition to your good answer about why we do the outpatient screen, and part of that is it's just national protocol. Babies are always going to get a chance to get an outpatient screen within that first month before we have to refer them to full audiologic eval. And especially, like you said, in New Mexico, where we don't have that many resources for the follow-up. That was basically it. Oh, and the why 2 ears at once. I tried to do research on that. A lot of it has to do with just how the brain hears and how the 2 ears work together. And so they have done longitudinal studies that showed that babies who passed 1 ear one test and 1 ear the other have a higher incidence of having hearing loss than those who get a good pass on both ears on the same test. So there's actually some data there to tell us why we need to have both ears pass on the same test. Does that make sense? Or does that help? Thanks, everybody.
All right. Well, we are going to go ahead and conclude our training for today. Thank you to all of our participants. Thank you to our panel. I still think this is a tricky time to work in healthcare. There's a lot of workforce shortages, and we just appreciate everything that you guys are doing to keep babies in New Mexico healthy and safe. So thank you for your participation. I will send out the slides for both the blood spot screening and the hearing screening later on this week. And certainly if you have questions, please reach out. Our goal is to support you and your facility in these programs. So please let us know how we can support you guys. Thank you. Have a great day.